All right, well, thank you very much for having me, and thank you to all those people who are giving up their evening to listen in. I hope this is of some interest. I'm a cardiothoracic surgeon at the Alfred Hospital, where we have a level 1 trauma centre. So I'm talking about thoracic trauma emergencies. And I think most of the people in the audience probably are already involved in thoracic trauma in many ways, so I'll try to make it as relevant and interesting as possible. So I think you've all seen this, this graph, which is very interesting. This comes from the trauma handbook, and essentially just shows us the historical trimodal timing of deaths in trauma, which we all know. There's the immediate deaths, and then there's this sort of golden hour coming up into 2 to 3 hours where there's a blip of deaths, and then there's the late deaths. And the good news is that with all of the improvements in trauma care, we've really been able to move and mould this trimodal distribution so that we essentially just have 2 main distributions: early deaths, which drop off over time because of the improvement in immediate care that we're able to give these patients, and then the late deaths, which are from a variety of reasons, such as sepsis and other complications. So there's certainly been improvements over the last decade or two. I think everyone on the call will be familiar with the ATLS Advanced Trauma Life Support modalities here with primary survey and resuscitation, the ABCDE. I won't go through all of this, and the secondary survey, which of course is very important. So we know that thoracic trauma results in about 20 to 25% of deaths due to trauma. The immediate traumatic deaths are generally due to cardiac or aortic rupture. The early deaths, which occur sort of in the first 30 hours, are typically due to uncontrolled thoracic hemorrhage, conditions such as tension pneumothorax, cardiac tamponade, or airway obstruction. And these are sort of the immediately life-threatening conditions that I thought I'd try and focus on tonight. Knowing the injury and the mechanism of injury is incredibly important in terms of assessing the patient when they come in, and being able to hone in on particular injuries that are part of the pattern of that mechanism of injury. For example, a patient who's in an automobile who's T-boned, we know that they're likely to have head injury, maybe cervical spine injury, lateral chest injury, and knowing the mechanism of injury is incredibly important. For stab wounds, and knowing that if they've been stabbed within that cardiac box, and assessing patients very carefully in that situation. So the causes of shock in trauma, first 3 causes are hemorrhage, hemorrhage and hemorrhage, and I must thank Kate Martin, whose slides I have stolen. There's a few of her slides in here, thank you, Kate. And then the other conditions that I've mentioned, such as tension pneumothorax, cardiac tamponade, and then other causes of shock. And cause is obviously relevant to the pathophysiology and also the subsequent management. So it's incredibly important, the damage control resuscitation on the field and then in the emergency department. And I won't focus too much on there because I don't go to the emergency department too often. But obviously early surgical decision making is incredibly important. Getting those investigations done, doing the FAST study, and early control of bleeding, and making a management decision for those patients. Obviously, the blood resuscitation is incredibly important in these patients, and we know that bleeding in these patients is associated with its own coagulopathy, and about almost 25% of patients who are in a major trauma develop a significant coagulopathy, and that can be as a result of a number of different things. It can be due to blood loss, and then hypothermia, dilution from crystalloid, and so many of these patients will arrive in the emergency department with well-established coagulopathy. So So it's very important to resuscitate them appropriately, and more than a decade ago the standard crystalloid-based resuscitation was challenged, and there's been an increasing focus on transfusion of packed cells and blood products. And we know that this can reduce acidosis and ongoing coagulopathy in these patients. And in fact, for patients requiring a massive transfusion, if they have a higher plasma to packed cell transfusion, that's independently associated with improved survival. So incredibly important to be replacing all of the blood products. Use of tranexamic acid has become quite topical. There's another study going on in Melbourne at the moment with ambulance delivered tranexamic acid. The CRASH-2 trial in 2010 in general trauma patients demonstrated a reduction in mortality. That was a randomised double-blind placebo-controlled trial of more than 20,000 patients. And there have been quite a few other trials since then which have continued to confirm a mortality benefit, particularly if it's delivered very early, so by the ambulance, really immediately on arrival, with very little downside, a very low complication profile. And if it can be given before the development of shock and before blood product administration, it seems to work better. Interestingly, the CRASH-3 trial, which focused more on head injury, has not shown as good results, but that will be for another day. Restricted volume resuscitation is also very important, and that's really came in the last sort of 8 to 10 years. It's showing that not overdoing the resuscitation with fluids is incredibly important. And over the last decade, we have seen a reduction in ARDS and pulmonary complications, and one of the reasons for that is probably not overflooding patients. And in this particular study by Duke from New Orleans, they showed really quite a significant improvement in mortality with restrictive volume resuscitation, with an odds ratio of 0.69 for mortality. So timely decision making is incredibly important. Appropriate volume resuscitation, treatment and prevention of hypothermia, and then rapid transfer to either interventional radiology for embolisation if required, or theatre for definitive control of bleeding. So I'll talk a little bit now about the more specific thoracic trauma conditions that we may see. And I think one of the most talked about conditions is tension pneumothorax. I think it's something that most people are taught quite early. Even the ambulance officers will treat a tension pneumothorax with bilateral thoracotomy if they're suspicious. So something that's life-threatening but easily treated. And probably no one on this call really needs to be taught how to put in a chest tube or teach it or identify tension pneumothorax. This is a fairly typical chest x-ray that you would see. There's not too much midline shift here, but probably enough pressure in that right chest to cause some compression of the SVC and IVC, causing hypotension. And of course, putting in a chest tube, an intercostal catheter is the mainstay of treatment. The ambulance officers may have already put in a very quick tube in the anterior second intercostal space, but the more formal tubes tend to be put in laterally. So you don't need to be taught how to put in intercostal catheters, but what happens when they don't really work? And as cardiothoracic surgeons, we often get called to the patient in ICU who is not responding to chest tubes, or the lung hasn't inflated, or they have terrible subcutaneous emphysema. And that's quite a common problem and can be multifactorial. It tends not to be life-threatening, but in a patient who's not intubated, they can get a lot of swelling around their larynx and vocal cords, causing respiratory compromise. And this is a pretty dramatic chest x-ray showing a very typical changes that you can see in subcutaneous emphysema. And what's even more typical is that they seem to have, I think I counted 4 chest tubes on the left side of the chest. And I'm not sure that you really ever need to put in 4 chest tubes. I think it's always worth putting in a second chest tube. And if they're correctly positioned, I'm not sure there's much to be gained by putting in a 3rd or 4th. So what do you do in the patient who's developing further subcutaneous emphysema? Well, really, one of the main things is to try and drain the subcutaneous space, and so we tend to put in subcutaneous Blake drains now, and that seems to help. Sometimes it's worth putting in a contralateral chest tube, just in case you're missing something that's coming from the contralateral side. The textbooks always talk about multiple cutaneous incisions to release air from the skin and subcutaneous tissues, and I must say I've never done that and I've never seen it, and it sort of sounds a bit horrific, so I'm not sure if really that's ever necessary, but I think a subcutaneous Blake drain or ready back drain can sometimes help, and then it's really just a matter of waiting. One of the causes could be a tracheobronchial disruption, and this is another life-threatening injury. It's quite uncommon, but it's usually very dramatic when it occurs. And it tends to occur with either blunt or penetrating trauma to the chest or neck, usually in a motor vehicle accident. It is quite rare, so the statistics are less than 3% of patients with significant chest trauma. And it does have a high mortality. Knife wounds can also be a cause, particularly high in the neck, so cervical trachea, transection of tracheal rings. Usually they'll be easier to diagnose, it's a little bit more obvious. But it's more the blunt injury and the sudden deceleration, which is the pathophysiology, which puts traction on the trachea usually at the carina. And often it will happen in a subsegmental area. So the most recent one that I did was actually the middle lobe bronchus had torn off the main tracheobronchial tree. And they really can be quite dramatic, but most of them do occur within 2 centimetres of the carina. So that's the area you need to be looking when you're trying to diagnose them. So how to diagnose them? Well, massive air leak, maybe ongoing subcutaneous emphysema. They may have hemoptysis, often not dramatic, because if they've torn their bronchial tree to the point where they've torn a pulmonary artery, then they'll usually die at the scene. So they're the main clinical presentations are really just a wound that opens into the pleural space, so a large pneumothorax, complete transection of the tracheobronchial tree, but little communication to the pleural space. And those patients may present a little bit later with a later presentation with atelectasis or pneumonia. So the diagnosis, chest x-ray, they're very difficult to diagnose. And as I've shown you in the previous x-rays, there can be so many causes of ongoing pneumothorax. But one of the things that might make you suspicious is a patient who has a pneumothorax and pneumomediastinum and subcutaneous emphysema. So if they have a lot of air tracking into a lot of tissue planes, then that should really alert you to a bronchial injury. Really, the definitive diagnosis has to be made with flexible bronchoscopy, and that's the gold standard. This is a 3D CT scan, which has diagnosed it in this particular case, but bronchoscopy is really the gold standard. And the management, most of them, if they're small and partial thickness, you may be able to treat them conservatively, but most of them are going to need a surgical repair. And you do have to be very careful when you're tubing these patients, because if it's high up and close to the carina, you do risk causing a complete transection or further damage with blind intubation. So if you have any suspicion, ideally you want to intubate under direct vision, although in reality a lot of these patients might already be intubated. Surgical repair requires a thoracotomy, and it can be a little bit tricky to identify the exact site, and so we will often use the flexible bronchoscope at the same time and get the anaesthetist to place the light from the bronchoscope at the site of the tear, and then you can just follow the light and find it, which makes it much easier. But if it's out to a second or third order bronchus, then you're out into lung parenchyma, and so it can get a little bit more tricky to find it. But usually just requires a couple of stitches. So penetrating cardiac injury, I think this is another clearly life-threatening condition that we don't see too often in the ED, fortunately, but there's enough there to sort of cause us some problems. I unfortunately had a recent case, well, more than a few months ago now, where both a mother and son were stabbed by the other son who was schizophrenic, and he managed to stab them both within the box. And of course, the mother looked hemodynamically much worse than the son, who was a young male. And so I sent the mother to theatre first, and the son promptly arrested in the emergency department, requiring an emergency department thoracotomy and oversewing of his cardiac laceration. So it was a reminder to me how young people's physiology can sort of make them look much better, and you can be caught out by how sick they really are. So emergency room thoracotomy, well, generally not indicated for blunt trauma. And I think everyone on the call here would know about emergency room thoracotomies. I would recommend this paper. It's a formalised expert recommendation looking at the first 48 hours of management in chest trauma. It's very useful. It just goes through expert recommendations for different conditions. So in terms of resuscitative thoracotomy in the emergency department, really a patient who has had an arrest with more than 10 minutes of CPR or initial asystole in the absence of tamponade, very poor results and probably not indicated. But for anyone who has penetrating trauma and hemodynamic instability or witnessed arrest after blunt trauma, they're the group that you do want to open up straight away, because there is a percentage chance that you can help those patients. So how to do an emergency room thoracotomy? Well, obviously the patient is supine, and one of the things I sort of always like to reiterate is even when we take a more stable patient to the operating room for a thoracotomy in the trauma setting, we always leave them supine, because you never quite know when you're going to need to call in the abdominal surgeons to do an exploratory laparotomy as well. You don't really know the status of their spine, so these are not patients who you put in a lateral decubitus position. And really most things you can do through the front of the chest. The cardiac surgeon doesn't leave the patients in a lateral position. And this reminds me of a patient I took to theatre who had been stabbed, and we could see a wound on his chest, and he was quite unstable. And when after I did the anterior thoracotomy and looked in and evacuated the blood, the entire blade of the knife was within his chest and actually penetrating the diaphragm and going into the liver. So most of the bleeding was in fact coming from the liver, not from the chest. So that was a situation where I had to call in the abdominal surgeon, liver surgeon, and they did a laparotomy. This image gives you a really nice illustration of how to do an emergency room thoracotomy. So inframammary crease, on the left-hand side, you're aiming for the 4th intercostal space, maybe the 5th. And you can do most of the incision with a knife. It's usually the quickest way to get in. But if you go through the intercostal muscles with a knife, you'll often pass point and hit structures on the inside, which in a thin patient could be a real problem. So I would suggest once you've got down to the intercostal space with the knife, make an incision in the intercostal space like you would for a chest tube, and then use a scissor and just run a big scissor along the intercostal space just above the rib below. And that way you can safely get in with minimal damage to underlying structures. And in this setting, what do you need to do? Well, you can see here the pericardium has been opened. I'm not sure if you can see my mouse, but you can see the phrenic nerve on the pericardium there, and then a longitudinal incision, which is anterior over the pericardium, which is the place to do it because you will miss the phrenic nerve in that setting, and then you can access the heart. One important thing is to just be careful of the internal mammary artery. Invariably, when I get called down to the emergency room to help out in a patient who's had an emergency thoracotomy, if the patient has a blood pressure, the internal mammary artery is almost always being hit and they are spurting blood out of this internal mammary artery. And in some occasions, they've been bleeding more from the thoracotomy than they were from the inside of the chest. So just keep in mind why the internal thoracic artery. I know in this setting you've got your mind on other things, but it only takes a moment to put a couple of clips on it or an artery forceps and just stop more bleeding. If the patient's truly shocked, it often won't bleed and it'll start bleeding later when we take them to theatre. So what to do once you're in? So open the pericardium, deliver the heart, have a look at the heart, looking for any cardiac injuries. Now, if there is a stab incision in the heart, I think just a big 4-O-proline or 3-O-proline, just a big needle proline to oversoak is probably the easiest and best thing to start. I know there has been talk about using the staple gun to close ventriculotomies that are a result of trauma, but the staple guns are so small, I don't think that would really work properly. You need to address any major intrathoracic bleeding, and if the patients were very unstable or little blood pressure, you can either cross-clamp the aorta just above the diaphragm. That's almost impossible to do. You'd be better off just putting a fist on it and compressing it, or getting an assistant to compress it. But finding the edges of the aorta to put a cross clamp on in that setting, it can be quite tricky, and you'll probably just push your instrument through the aorta. Obviously start cardiac massage if you need to, and if there's blood in the right chest, then just extend the incision into a clamshell thoracotomy. And I've got a picture of the clamshell thoracotomy coming up. So one of the other things you can do if there's a lot of bleeding coming from the lung is you can try and put a clamp across the whole hilum of the lung to try to stop bleeding. That's sort of pretty desperate, but that's something you can do as a stabilising procedure. To extend your incision to a clamshell, you do need a saw to get across the sternum, and then you just really do a mirror image of the thoracotomy incision on the other side. And this is the standard incision that we used to use for lung transplants. We don't really use it much anymore, but you can see it gives you fantastic access to everything inside the chest. So sometimes that is necessary if you want to have a really good look at the arch and check the thoracic cavity on both sides. So when does the patient with thoracic trauma need to go straight to the operating room for a thoracotomy? And those patients will often already have chest tubes in, and there is concern about the amount of bleeding. Really any significant bleeding and a massive pneumothorax is defined as more than 1,500 mils blood loss through the chest tube, or ongoing losses of more than 200 mils per hour would both mandate a visit to the operating room. A large clotted pneumothorax, which needs to be evacuated, and anyone with a great vessel injury, significant pericardial tamponade that you haven't been able to correct, bronchial injuries we mentioned before, some ruptured esophagus and ruptured diaphragm. Now, blunt aortic injury is Another not infrequent injury that we see, particularly motor vehicle accidents with that rapid deceleration. And this used to be the purview of the cardiothoracic surgeon, but we're really not involved in aortic transections anymore. I don't think I've done one since I was a registrar. So just a word on nomenclature. A blunt aortic injury that occurs as a result of trauma is an aortic transection, as opposed to an aortic dissection, which is a different pathophysiology and more related to weakening of the aortic wall as a result of an aneurysm and hypertension. The diagnosis of aortic transection, well, you should be suspicious if you can see the patient with a widened mediastinum, as shown on these chest x-rays, and then it will be confirmed on imaging with either a CT, aortogram or a fluoro aortogram, and you can see the arrows pointing to the very typical position of the aortic transection, which is just past the subclavian artery, where the arch of the aorta and the descending thoracic aorta have a differential movement in that rapid deceleration leading to tearing of the intima. And these are typically managed by stenting now, which really is a much better option for these patients. In the past, we would take them to theatre and have to put them on cardiopulmonary bypass, and they often have other injuries which would bleed, and stenting does allow the condition to be more rapidly fixed with less morbidity. Clearly, it is time critical, and I think most people on the call will be aware of cases where the patient hasn't quite made it to the angio suite. And, you know, it's surprising that more of these patients don't die because often they're just hanging on with a little bit of adventitia. So quite a critical injury. I won't talk too much about that because I know we've got vascular experts on the panel who can talk about that. So I'll go on to rib fractures, which is sort of part of my sort of interest area. And a lot of people think of rib fractures as a secondary injury in the thoracic trauma patients. But it's incredibly common and it can have quite significant morbidity and mortality impact. So rib fractures occur in 10% of all trauma patients. They occur in about 30% of all thoracic trauma patients, and they're often associated with other injuries, as we know. There has been quoted to be a 10% mortality in patients with 4 or more rib fractures, and that mortality has been shown to increase to 34% with 8 rib fractures. Now, that data is a little bit old now. It's come from 2003, and I think we're doing a little bit better. But even so, it's still quite significant consequences for patients with rib fractures. We know that patients with more than 4 rib fractures and who are older than 45 years have an increased risk of adverse outcomes. And so those figures continue to be an inflection point even in our current management of these patients, age of 45 and more than 4 rib fractures. We know that of patients who are more than 65 years old, 50% of their mortality rate in these patients who have multiple rib fractures is actually due to their rib fractures and not other injuries. So they really do have a significant impact on mortality. And of course, about 30% get pneumonia, prolonged respiratory failure, hospitalisation, ventilation, and all of the iatrogenic complications that come with that. So this is a patient with a flail chest, and you can see here he hasn't been intubated yet. He's in the emergency department, and you can see quite clearly there's a sort of left anterior flail chest. Flail chest mortality rates of up to 50% have been quoted. And the most recent big series that I've been able to find was from Canada, where they trawled their national trauma data bank, more than 3,000 flail chest patients. And it's pretty concurrent. I mean, it's a decade old, but even so, the mortality rate from flail chest was 16%, so it's still quite significant. And those patients do have a lot of potential complications. We know that elderly trauma patients with rib fractures are at a much greater risk of death and pneumonia, and this is quite a good paper. And if you look at the graph, we're looking at two lines. The higher line are the patients who are more than 65 years old, whereas the lower line are the patients who are less than 65 years old. And in all the patients, as their number of rib fractures increase, along the x-axis here, you can see that their percentage risk of mortality increases. But there's quite a significant difference between the two age groups. So that age of 65 is another important inflection point in outcomes that we take into account when deciding the management of these patients. Another important point is the variation in injury in these patients with age. And as you know, younger patients have much more elastic ribs, and so they're less likely to fracture their ribs, and you can see the dark hatched bars are the rib fracture injuries. But because they're still subjected to the same chest wall force in the trauma, that is transmitted to their lung, and so lung contusion is much more common in these younger patients, even though their chest wall appears to be intact. And then you go to the old patients who have more brittle bones, and they will break their bones much easier, but they have much less parenchymal injury. So they're getting loss of chest wall integrity with lower force injuries. And that does impact on their outcome. So in terms of the most sort of up-to-date clinical evidence, there's been a huge number of meta-analyses come out on rib fixation, which I'm quite critical of because there's only ever been 3 true prospective randomised controlled trials proving that rib fixation is of benefit in flail chest patients, but there's already been 8 meta-analyses. So I don't know how you can do 8 meta-analyses on 3 papers. It seems a bit ridiculous. But this is one of the latest ones, which I thought was very sensible. And so I'll just read out the conclusions here because I think this is quite important. In adult patients with flail chest after blunt trauma, we conditionally recommend rib fixation to decrease mortality, shorten duration of mechanical ventilation, length of stay, pneumonia and need for tracheostomy. And we cannot offer a recommendation for pain control with currently available evidence. And that is very true because there has not to date been a prospective randomised control trial proving any improvement in pain in these patients. And in particular, in adult patients with non-flail rib fractures after blunt trauma, we cannot offer a recommendation for any of the outcomes with currently available evidence. And we were just talking on the panel before this Zoom meeting started that we have in fact just finished the Australian multi-centre non-flail rib fracture randomised control trial. And hopefully if we get it published in the next few months, that will be the first time that's been done in the world. And quite a few of the panellists were involved in that trial. So that'll be very exciting to see the results. So this meta-analysis, just to go through what I just read out, you can see on these forest plots, mortality, it favours rib fixation, duration of mechanical ventilation, again favours rib fixation. It's important to note that most of these trials are not randomised controlled trials. And again, we've got ICU length of stay, favours rib fixation, and hospital length of stay, favours rib fixation. So there's certainly a lot of benefits there, and enough that rib fixation has become pretty standard in level 1 trauma centres for patients with flail chest in particular. One of the more interesting aspects of rib fixation now is the timing, because for the last 10 years it's just been slowly gaining ground in terms of acceptability, but because it wasn't mainstream in many ways, it wasn't done immediately. And I think this was a very important paper that looked specifically at the timing of rib fixation. And in most places, even now, I think all of the other surgical specialties will get in first,
before anyone considers rib fixation, and it might only be days later when we can't get the patient off the ventilator that someone says, oh, should we be fixing their ribs? So this was quite a good study from Fred Pieracci, looking at about 500 patients from 4 centres in the States, and it was prospectively collected data, but it wasn't randomised, and they were looking at early rib fixation, which was within 24 hours, mid, which was 24 to 48 hours, and late, which was more than 48 hours, and they had about 30% of the cohort in each group. And then looking at, if we just look at the sample demographics, they were fairly well-matched patients. I don't think there were any specific sort of differences of note in the demographics. And then if you look at the operating room variables, just jump ahead there, you can see this is just a histogram of the days from admission to surgical rib fixation. You can see over in the States, a large percentage of these patients have been done within 24 hours. And I must say, my own personal practice, we don't really even get the referral in the first 24 hours. So they've been incredibly quick in the States. And if you look at the outcomes, so univariate outcomes, comparing early, mid and late, you can see hospital length of stay was significantly different between the 3 groups, which I think is predictable. ICU length of stay, if you wait longer to fix their ribs, they're going to stay in ICU much longer. And of course, that translates into complications. They have more mechanical ventilation, and then after controlling for covariates in the multivariate analysis, they found that each extra day prior to rib fixation was associated with a 31% increased risk of pneumonia, a 27% increased risk of prolonged mechanical ventilation, and 26% increased likelihood of tracheostomy insertion. So it really does impact on the outcomes. And the same group did another paper, probably on the same patients, but just looking at how that translates into costs in this group of patients. And it's quite interesting. If you slow down your management of these patients in terms of rib fixation, you lose money. And they found a $35,000 saving for each day earlier that they did the rib fixation. In addition to the operative management of rib fractures, 30% of the variance in charges in these patients are accounted by scapular fractures and long bone fractures, and as well as being impacted by bilateral rib fractures in Glasgow-Combs form. And just to finish up, this is a patient who was a driver in a car, single occupant, drove into a tree and really ruptured her anterior chest wall, and in fact the ambulance record comments that the steering wheel was bent by her chest wall, and you can see she had quite a nasty disruption and flail chest injury. You can see here we've done like a sternotomy incision curving down into an anterior thoracotomy incision, and this is the edge of her chest wall, which is completely ripped off her sternum at the costal cartilages. So she underwent quite a significant rib fixation with an excellent result. But I bring this up to point out to you the injury that we missed. So while we were congratulating ourselves on the fantastic rib fixation, you note that when she came back to see me 3 months later, we'd clearly missed a ruptured diaphragm on the right side. I've run out of time to tell you more about ruptured diaphragm, but I'll leave that for another day. Except to say that maybe maintaining a high suspicion is important, and that thoracoscopy is really the gold standard to diagnose it, particularly early on when it's not so obvious on imaging. And so in summary, the role of the surgeon begins in the resuscitation room with the emergency department staff, and the decision-making and early
management decisions are incredibly important in saving that patient's life. And I think I'll stop there. Thank you very much for your time.
Thank you very much, Silvana. Much appreciate that. So just for our audience there, what we're going to do there, I will apologise just for the sound quality going in and out. It is all to do with Wi-Fi speed, so there's not much we can do from our end, but if you bear with us, most of the time we can hear clear enough. So I'd like now to welcome back our panel who are going to field questions from the audience. We've got a few coming in. So if I could all just remind you, please don't be shy. You don't have to ask them in person. We'll ask them for you. Send your questions through. And as that happens, I'm going to kick off with the first question. And I guess some of which I might know the answer for, so there might be some slightly rhetorical questions. Sorry, Silvana. One of the things we're often asked or people suggest, particularly in the situation where you've got an arrested or an arresting patient, you've essentially lost output, palpable pulse, is it quicker to go for a sternotomy if you have the expertise there and the equipment, or are we better off going for a left anterolateral thoracotomy with a view to doing a clamshell? This is for a suspected or confirmed tamponade or something along those lines. Clearly chest trauma.
Yes, I think it's always quicker to just do a left anterior thoracotomy. You always have the equipment on hand that can get you into the chest through a thoracotomy. I mean, all you really need is a knife and a scissor. And, you know, even in theatre and cardiac surgery, we get handed up the saw for an elective case and the battery doesn't work, or you can't get the saw, or the blade flies off. And in that emergency setting, to get someone who's unfamiliar with a saw to open up the sternum and then do it in a safe manner so they're not going off the side, I think is near impossible. And if you do go off the side, the chest never opens evenly and then you have terrible view anyway. So I would always go for a thoracotomy.
Yep. Can I ask Jodie Kate just to, if you've got anything extra to add to that, just with your experience up in Darwin?
So I would definitely agree in terms of the thoracotomy. We even have trouble, we actually have 3 sets of retractors in the hospital that get taken apart in the CSSD, but they're all different sets. So in fact, we went through a stage where, you know, you'd open the tray in ED and the retractors were not the retractor that you needed or the parts. So even that for us was a struggle at a time, getting that set of equipment. So the thought of actually having someone try and work a saw for us, it's not going to happen. Yeah, and I guess, you know, it's in terms of comfort level as well. So for us, you know, our nearest cardiothoracic surgeon is a 4-hour flight away. And most of us are much more comfortable with doing a thoracotomy rather than a sternotomy to start with. So that's probably where I'd be coming from anyway.
Thank you.
So kind of, I guess, on that theme of like the, you know, what to do in the resuscitation, there's a question that's come in about autotransfusion. And this, I think, was talked a lot about, like, kind of historically, you know, there seemed to be like a lot of interest in autotransfusion, and in particular, there's some potential benefits, I guess, in the rural setting or where there's not the blood product availability. Because, you know, Silvana, you talked about like the damage control resuscitation. I just wanted to get to answer that question about what's the preferred technique and what's the role, do you think, of autotransfusion nowadays?
Oh, for me, or
yeah,
you?
for you, Silvana, first of all.
Jeremy, you would know more about this than me. Yeah, I don't see autotransfusion done very often, but right. I think if you're in a country setting and you have limited access to blood, there may be certainly a role for it, but I've certainly never been involved in autotransfusion in metropolitan Melbourne. So I don't really have a good feel for that, I must say.
Okay, so that's exactly what I was suspecting, like, is in most of the metro major trauma centres. So I guess then, Jody, auto transfusion.
So we would probably not use that in the emergency department, only because it takes an extra person. It takes all of that time to set it up. We do occasionally use it in the operating theatre. We try and do that there. We are lucky in that we are still a major hospital and we have access to blood, but if we get a major trauma in, they will often use up all our blood resources for the territory. Particularly, a lot of our patients will have antibodies to blood. So that becomes a huge problem in that we can't transfuse them with the blood that we have, or we need to fly blood in from interstate. So that does become a huge issue for us. So actually, auto transfusion is something that can help get around that a little bit.
Yep. So do you have systems or techniques that are in the resuscitation room or things, outside like the formal cell saver?
Yeah, so we use the cell saver and then mainly in the theatre setting. We can use it in the emergency department, but it would be, it just takes the time to set it up a little bit. And I suspect we often don't really have the space for it, I guess, in our resus rooms, but we definitely use that in theatre, not infrequently.
All right. So maybe, Savitha, what about in New Zealand? Is there auto transfusion in the resuscitation room?
No. We have used it in some semi-stable patients who've had cardiac injuries and who make it to the theatre. We do have a little bit of time to set it up, but we usually don't use it in the emergency department, really. And like Silvana, it's very rare for Auckland to run out of blood in case of trauma, so we do have supply. So we don't set up an auto transfusion automatically in these cases.
It's interesting. We definitely have had one of my vascular colleagues who does a lot of work in austere environments talks a lot about auto transfusion because it's it's actually fairly simple. And I've only done it actually in a pig experiment as part of the pig experiment where we bled them and then we collect the blood in a bag and just inject citrate as an anticoagulant and then you reinfuse it. So it actually, there's lots of complicated systems that seem to be out there, but it seems like that even in, the rural setting and in most metro settings and, across two countries, that certainly the experience here is that auto transfusion is not really used a whole lot except like, maybe in the operating room.
Yes, and we would use the cell saver pretty routinely in the operating room. But even when you're collecting the blood and transfusing back the packed cells or the red cells, you always have to remember that the cell saver actually filters out all of the other blood products, other blood components. So you have to supplement it with the platelets and the FFP and the cryo. So you save some red cells, but you don't save much else with it.
Thank you. All righty. There's been a question with regards to a penetrating injury in the cardiac box, and I might direct this to you, Bruce, if that's okay. The question is, do you go for peripheral cannulation or just go straight to sternotomy and see? And by that, I think that the question is referring to some form of bypass before opening up the chest, or if the patient has an output, you just open up the chest and see what you've got first. How would you approach that?
Sorry, I was having trouble turning on my mute. Could you just rephrase that question?
Not a problem. So the question's regarding penetrating injuries in the cardiac box with a patient that you've been able to get up to theatre. Do you do a peripheral cannulation first, anticipating you'd need some sort of bypass, or do you go straight to a sternotomy and have a look and see what you've got first?
So
I think I've interpreted that correctly.
Yeah. So if the patient is stable enough to make it to theatre, then we would do a sternotomy first. And most of the time, the injury can be repaired without having to go on cardiopulmonary bypass.
How often would you need to go on bypass, do you think, in your experience?
For penetrating cardiac injuries, very rarely.
Yeah.
Like as Silvana nicely outlined in her talk, a 3 or 4-O-proline with a 36 millimetre needle is usually all that you need.
Yep. Excellent. Any of the other panellists got anything to add to that? Any tips and tricks on stitching up the beating heart?
Yeah, I think the only time you may have a cardiac injury as a result of trauma that needs bypass is often down the track when you realise they've ruptured their tricuspid valve. That tends to be the most common thing. They can sail through and, you don't pick it up initially, and then an echo a few days later, you realise, oh gosh, they've got severe tricuspid regurg, and then it becomes a more semi-elective cardiac case.
Yep. Okay, Jeremy.
Yeah, so I actually had a question that I wanted to bring in Joe's thoughts about it, because Silvana, you mentioned that you haven't done a repair for a blunt aortic injury for quite some time.
Yes.
And I wanted to first check with Bruce, is that also your experience?
Yes, so I'm a little bit older than Silvana. So when we started at Liverpool in the mid-1990s, we were doing about 2 a year, and they were all done open. And the results were variable. And then around about 2002, 2003, our vascular surgeons developed an endovascular program. We were perhaps a little later than Prince Alfred and other hospitals. They started to do traumatic aortic ruptures, and they had much better results with lower paraplegia rates, lower perioperative death rates, a lot fewer ICU days. And the only ones that I have been asked to do since then were with the very earlier endovascular stent grafts that didn't tolerate the curvature of the aortic arch that well. And so the very early Cook stent grafts used to, I think they were the Cook stent grafts, they had a tendency to actually sit up in the aorta so that they partially obstructed the aortic arch and created a sort of a coarctation type of picture. And so there have been 2 patients in the early days of our endovascular stenting that I've had to actually remove the grafts and do an open repair electively for that reason. But we have not done an open traumatic rupture since about 2003.
Wow, yeah. So, Joe, is that are you responsible then for repairing all down in Adelaide, all of these blunt aortic injuries?
Yeah, sorry guys about that. I mean, I think, yeah, with the stenting, it really transformed the upfront costs in terms of mortality and paraplegia. And, you really have a completely different physiological insult to the patient with stent grafting. But you do, there's no such thing as a free lunch, and we do have long-term costs now. We don't know what they're going to be. Bruce was talking about putting in these early iteration Cook stents, which were designed for elderly atherosclerotic patients, and they're really designed for 10 or 15, 20 years of use. And so putting them into 20-year-olds, we just don't know, whether we're going to have a lot of complications down the line. What tends to happen if you've got quite an acute aortic arch is the phenomenon that Bruce was talking about, which is bird beaking, and the aortic stent doesn't open up properly, and then that can collapse, and acute collapse of the stent is catastrophic and usually fatal. And then one of the other issues, and Silvana was talking about it being a time critical thing, which I think we may be moving away a little bit from. So if you're putting in stent grafts in underfilled, under-resuscitated patients, you're putting in, you're maybe getting your sizing wrong on their aorta. And so if you make sure that they are resuscitated, you tend to get your sizing a bit more correct, and that might not cause problems down the line with stent migration. The thing to remember about aortic or blunt aortic injury is that those ruptures usually die at the scene or pre-hospital. And then we've got a big group of about 25% that are low-grade injuries and intimal injuries, which we're tending to treat a lot more conservatively now, actually, and maybe just rescanning them and seeing what happens. Ben Starnes from Seattle came up with a new improved grading system, which asks the question, do they have an aortic external contour abnormality or not? And that's really the big thing. And if they do have that, then essentially they've got a pseudoaneurysm. But we probably think that there's a bit more time to treat that. So if you've got a shocked patient who has a blunt aortic injury, you really need to look for another cause of that in their abdomen or elsewhere, because usually that's where it is, and it's very uncommon to have an isolated injury. And so we know now that maybe we've got a bit more time to treat these patients in 24, 48 hours or even a few days. So it's an evolving space and an interesting one.
Great. So Kate, I think there's a few other questions.
There are. I'm going to ask some questions now about rib fixation or the decision to make, and I'll put a couple of them together. There's one question with regard to the patient with the flail chest wall injury that you consider for rib fixation. So I'll start with you, which is Silvana. Is it, do you look at someone, consider them for ORIF based on a clinical or a radiological flail only? Do they have to have that clinical evidence of flail? And then the other question that goes inside with that is time to operate. Is this a decision that you make relatively early on, and it's just a delay, it's getting into theatre or the priorities of the other injuries, or is there often a delay on decision to operate which can influence length of stay?
Yeah, so hopefully it's not a delay on the decision. I think the evidence in flail chest is fairly clear. So if they have a flail chest injury and a ventilator dependent, whether it's a clinical flail chest or a radiological flail chest, if they're ventilator dependent, I would err on the side of taking them to theatre. That's all the evidence suggests there's a benefit there. Sometimes there are very subtle radiological flail chests, which you read in the CT, and then I look at the CT and I think, gosh, I can't even see these fractures. They might be little hairline fractures. So I might resist taking them to theatre. But certainly if they are displaced fractures, I would take them to theatre. I'm finding, particularly since I did the first randomised control trial, less and less of these patients are needing ventilation. I think the intensivists and the trauma surgeons are much more aggressive in terms of keeping these patients off a ventilator, putting in local blocks like erector spinae blocks, serratus anterior blocks, paravertebrals, getting their pain controlled. So they're changing the group of patients. Now they're flail chest patients who are not ventilator dependent. And so the data there is a little bit more wishy-washy. So you probably need to take a little bit more, use a bit more clinical acumen in making the decision to operate on those patients. And usually I would go and see them, assess their pain, see if they're improving, are they deteriorating, and use that as my guide whether to operate. If they do have severely displaced rib fractures, then I still would offer them surgery. But if their flail chest is not displaced and they're sitting on the ward on 2 litres of oxygen with a paravertebral in and it's been weaned, then I wouldn't take them to theatre. I don't think the data is there to do it. I think the patient should be operated on as soon as you sort of make the decision. The earlier the better. All of the evidence seems to show that. So there shouldn't be any delay. Sometimes we go and see a patient and they look like they're improving and we might wait another 24 hours and go and see them the next day and they'll say, no, I'm not interested in any surgery. I think I'm walking out of here in 2 days. So sometimes a patient makes a decision for you.
Savita, I'm just wondering if you've got anything to add to that with your experience in Auckland.
No, that's pretty much what we do as well. I trained under Jeremy, so my indications are very much in as what Jeremy does now, 3 or more rib fractures, bicortical displacements. I guess as Silvana said, the pain factor makes a big difference and therefore the patient factor modifies the outcome. So there are patients who've got bicortical displacements and they don't feel a thing, and they're walking around, going out for smokes, and it's ridiculous to fix their ribs because they really don't need it. And there are some of them which is barely displaced, but they are in severe pain. And in those patients, we have fixed them. One other thing which I struggle with, and probably Silvana can guide me, is whether we fix both the fractures in the flail. So it's a big question. I used to religiously fix them, but now my decision is based on the axis. If it means I have to make bigger incisions or cut through muscles, then I try not to. But I can't find a correct answer for that. I'll be glad to be guided by others about this.
Yeah, that's a very good point. And I don't think there's a clear answer, but we do know that if a patient has two long lines of rib fractures all down their chest wall and you just fix one side, the other rib fractures do tend to displace over time, particularly the posterior fractures, because the action of serratus anterior on that lateral chest wall tends to pull the ribs back and overlap. And so the patients do get a lot of deformity. Now, so I tend to operate on both ends of the ribs, but look, it's hard to know exactly what the right thing to do is there. And I think you're quite right. If you end up making multiple other incisions and cutting chest wall muscles in order to restore integrity to the chest wall, that sort of seems a little bit counterintuitive. Yeah. There is a new intrathoracic rib fixation product that is just coming to Australia, and we're about to start a pilot study using that, and that's going to be done thoracoscopically, and that will make accessing those posterior fractures much easier. So I'm really looking forward to getting that started and seeing what the outcomes are like.
Okay, I think Joe's got a question now for you, Silvana. Joe Dawson.
Yeah,
a question from the panel to the panel.
Thanks for the talk, Silvana. It was great. I've got a couple of questions sort of down the track with the patients, and I see a lot of varied practice, and I just wondered your feeling on two things. One is you talked about the ongoing air leak or the pneumothorax that doesn't come up. Do you add a second drain? But I wondered what your use of wall suction was in that scenario, because that seems to be very variable. So that was one question. And my second question, again, something that I think we kind of don't do quickly enough, or we keep seeing how they'll go the next day, and that's really the timing of VATs for a retained pneumothorax. You know, you've got a drain in, they're not terrible, but the chest X-ray is not, really improving. There's a bit of blood retained there. How aggressive should we be? How quickly should we get in on those?
Well, thanks, Joe. That's great. Yes, so I think in terms of the chest tubes and thoracoscopy, I think an earlier VATS is better. We know that retained hemothorax, if it's left too long and you try to drain it with multiple chest tubes, you do end up with a higher risk of infection and empyema. And I know when I started getting referral cardiothoracic surgeon.
Silvana, we might just get you to repeat that if you can hear us, because I think you've got dodgy Wi-Fi again.
Oh, yes, I just...
Let's just try that. Maybe, maybe not. Maybe while we're getting Silvana's dodgy Wi-Fi back, Bruce, would you like to have a go at answering that question?
Yes, certainly. Look, let's go for the hemothorax first. There are hemothoraces and hemothoraces. There's the massive exsanguinating hemorrhage that requires an emergency room damage control thoracotomy, and Silvana more or less dealt with that. There's the small hemothorax that is, I would say, less than 2 centimetres on an ultrasound, or just blunting the costophrenic angle, and they can probably be safely looked alone if the patient's otherwise stable with a follow-up X-ray. And anything bigger than that, I think probably should have a chest drain. So bigger than 2 centimetres and bigger than just blunting of the costophrenic angle. And the role of a BATS procedure, or some people might even do a thoracotomy, is if you have a retained hemothorax that doesn't resolve after a week, or if it increases in size after a few days. And the reason why early surgery is beneficial in these people is that it prevents them from developing a later fibrothorax as a result of with a resulting trapped lung and chest wall scarring, and the need for a much more morbid procedure of a pulmonary decortication. So in my experience, somebody who doesn't require urgent surgery still has to be assessed more or less on a daily basis for their need for early surgery. And in my hands, these cases can be more or less done all by VATS. There is perhaps one other consideration that is in the literature that you will come across, and that is whether or not thrombolytic therapy can be used in clotted hemothoraces. And the evidence for that, in my opinion, is not there. And it's an extrapolation of evidence for thrombolytic therapy in the management of empyemas. And there were 2 randomized controlled trials. There was MIST-1 and MIST-2 that some of you may be familiar with in the setting of empyema. And there are only a few case reports and observational studies of thrombolytic therapy in the presence of clotted hemothoraces in trauma. And there's not really any real evidence, and we have never really done it. And I would always advocate that the patients have open surgery.
That's great, Bruce, that you do that, because I was about to ask you exactly that point about thrombolysis and the role of that. So thank you for addressing that. So we've got another question. Actually, this is an interesting question, which I think I might we'll jump back to, because we talked about aortic injuries. So there's a question that's come through about how would the panel tackle a 19-year-old man with an aortic injury at the level of the ligamentum arteriosum, but the vessels are too small for endovascular repair? I guess I might start with Joe to see, I guess, number one, is there any vessel that's too small that you can't put a stent in? Because I figured that you can access anything, just like in the house of God, with the except you can replace that statement with a stent. Now, there's no vessel too small that you can't access with a stent?
Absolutely. You've answered the question for me. Thank you. No, so seriously, I guess, first of all, I'm trying to sort of slip my way out of answering the question by first saying what is this aortic injury? Because as I said, there is a role for conservative management of lower grade 1 and 2 aortic injuries with close observation and cross-sectional imaging. So, you know, so essentially, if we're talking about a horrible grade 3 pseudoaneurysm, there is the new iteration of one of the manufacturers of stents has now gone down to really quite a small diameter. So they're pretty much most, I mean, it comes back to what you said, Jeremy, but most aortas, unless they're very small, you know, you would be able to. But I guess I'd be on the phone, you know, to Silvana and Bruce and talk to them about, you know, is this something that we would have to do an open repair on? So we've got a bit more information about so definitely can't stent it. So yeah, I think, you know, in that scenario, if it is an injury that needs treating, then you might want to talk about an open repair.
So, Silvana, how would you tackle this scenario?
I think I've still got an unstable connection.
Oh, well,
no good.
No, you're okay.
Okay, good. Yeah. All right. Well, I think Yes, if it looks too dangerous to leave it for conservative management, then we would have to operate. I mean, we can still do the open operation, but it does mean a large thoracotomy, partial bypass, but we can do an interposition graft. It's a pretty quick, straightforward operation. It is a lovely operation to do most of the time. And I think, you know, that would have to be done but I don't know if you do it for 25% circumference injury. You might want to sit tight and see. I'd have
Bruce?
to see imaging.
So look, I think one needs to have a careful look at the arch. I've not actually seen any pictures, but these ruptures can occasionally occur in the arch itself. And one of the important components of an open repair is to get a cross clamp above the rupture and have enough aorta to sew a graft to below the cross clamp. Usually the cross clamp is between the left common carotid and the left subclavian, and then the left subclavian is separately controlled. But if the disruption of the aorta is too proximal for that, then the surgery has to be done from the front, and it has to accommodate arch replacement techniques. Which can be done, but it would be a rather risky procedure to do in the context of acute trauma, and it would be preferable if the patient could wait and some of the major injuries and contusions could settle down before profound hypothermia and cardiopulmonary bypass techniques from the front for arch procedures. So we've actually not done any of those for trauma before. We've had penetrating wounds to the arch, which we've managed to repair just without bypass. We've had penetrating ulcers, which are due to atherosclerosis, and of course we've had dissections, but not traumatic ruptures that have required arch replacement techniques.
Yeah, you can see there's I think this is a patient of Dr. Mary Langcake's, and it keeps getting worse and worse. I think we might leave it at that point because Mary, you're challenging, and this is getting harder and harder. So we might leave that one and move on to the other questions that we have because we're running a bit close to time.
There was a question about air leak before, which was never really answered, and maybe we should address that.
Yeah, that was.
So that was my question, and it was essentially, what are your feelings on wall suction? You know, you've put in an additional drain, the lung's still not coming up. Some people use wall suction very freely, some people don't. I just wonder what your views were.
Okay, so I always use suction, and most of the drains, in fact, virtually 100% of the drains that get put in at Liverpool Hospital are put in by the trauma team and managed by the trauma team, and they all go on suction. And we put in large drains. We put in at least 28s or 32s. Occasionally, they'd even put in a 36. And I think that your other question, I think, might have related to the patient who's got severe subcutaneous or surgical emphysema, and they've got 1 or 2 chest drains in. These are, in my opinion, very difficult patients to manage. They frighten the staff and their relatives more than they usually frighten the medical staff. So the nursing staff are constantly concerned about the fact that they can't open their eyes and they start to hallucinate, or their voice goes very husky because of surgical emphysema within the mucosa of the larynx, and they end up having MET calls and lots of clinical reviews. And in my opinion, the most effective way of managing them is to place a drain at the site of the air leak, which is inside the chest. And generally, that's only possible to do if you have the chest open and are looking at the lung. At that stage, you'd obviously be in theatre and you'd fix the leak. So I don't think that subcutaneous incisions are anywhere near as helpful in controlling these patients than controlling the source of the air leak by placing a proper chest drain and then putting it on suction. We have on occasion put in Blake drains underneath pec major muscle. Occasionally we've made incisions and put back dressings on them and sucked on that. But most of the time the surgical emphysema persists until the air leak from the lung stops. Maybe Silvana would like to say something about that.
Yes, I would agree with all of that, Bruce. I always use suction. I can't really see the point of not having it drain on suction. If the lung is not inflated, I think you definitely need suction. Sometimes you might turn down the suction. So if the patient has a very big air leak and they're actually having difficulty ventilating the patient because the air leak is so big, then you would turn down the suction. But that in itself may be an indication for theatre. So I don't think you'd be sort of sitting around off suction in a setting like that for long. And again, ongoing air leak, really, if it's getting towards a week, you need to be thinking about going in and doing a thoracoscopy and working out where it's coming from. Or if the air leak's so big that it's difficult to manage, then go in earlier.
Thank you, Silvana. The next question, I'm going to ask one of my own questions too, because it follows on from that. It's quite rare, but in the event of a large air leak, it's trouble ventilating the patient. You often hear about the manoeuvre of advancing the ETT down the good side. I only ever seen that needed once in 12 years as a consultant, and the rest. Is that so? If we're stuck with a patient with a bad chest injury and we don't have access to a thoracic surgeon, we're either waiting for someone to come in or we're looking at transferring that patient. Is that something that can be considered, and what needs to be done to do it safely?
Well, you would probably need bronchoscopy to be able to safely advance the tube in that setting. I mean, that patient may have a tracheobronchial injury, so probably a bronchoscopy is necessary anyway. I think you could advance the tube down the good side if that good side is not too contused and it's good enough to keep them going and ventilated while they're transferred. If you had an anaesthetist who's comfortable with a double lumen tube, that may be a good option, because then you could still ventilate that. You could have differential ventilation on both sides with different pressures, different volumes. That would be an option. Or if you're desperate, put a bronchial blocker down the bad side rather than advancing the tube down the good side. So there's a few different options just to get you out of that tricky situation.
Thank you. Now, we've still got another couple of minutes. So there was a question, and this is a hard one. I'm not sure if any of us are going to have the good answer because we don't see it much. Esophageal trauma. Now, in the rare event that you find an esophageal injury in the context of a severe chest injury, what would be the best, particularly the initial approach to this, an endoluminal vac or some sort of diversion technique? And I'm not sure who in our panel, so maybe Savitha or Bruce, you might have something to contribute to this. I must confess, I'm yet to see a decent esophageal injury that has needed anything other than a nasogastric tube.
Okay, well, I've not ever seen esophageal trauma before. So that doesn't mean that it doesn't occur. They tell me even the thoracic duct is a culprit of blunt trauma occasionally and penetrating trauma, and I've not seen that either. Just thinking about it, probably the way to do it would be to sew it up early and then drain the mediastinum, which is the procedure that would be done, say, in a Boerhaave syndrome.
We use stents a lot, covered stents, and nasogastric feeding. that works pretty well. If it's a delayed presentation, then yes, we would treat this as any other esophageal rupture like a bore house. You drain the mediastinum, divert the ends. But in acute setting with trauma, as Kate said, most of the time it's NG tube or a stent, covered stent.
Savitha, can I ask, does the covered stent come out once it's healed?
Yeah, 6
Oh,
weeks.
right.
Yeah, it does.
Oh, okay.
Yeah.
Well, look, it's 7 Australian Eastern Daylight Saving Time. I appreciate it's not that time everywhere where our audience is. So I am going to bring the webinar to a close now. I'd like to say a very big thank you to Silvana, as well as Savitha, Bruce, Joe, and Jodie Kate, all online. Thank you very much for your time. Also, very much thank you to our audience, our participants, and for all your questions that you've sent in. I think we got to most of them in there. So thank you very much for joining us. I am just going to share my screen now for 1 minute. We do appreciate any feedback that you can give us as well. You will be sent an email this evening after the webinar concludes, which will give you a link to a very, very short survey, just for some feedback on tonight's seminar and what you'd like to see in future grand rounds. If you're not an ANZUS member and you're interested in joining, check out what we have at anzus.org and you'll see what the benefits of membership are. And I would again just like to say thank you to our sponsors for this evening, Medical and Optical. Now, our next Trauma Grand Round, ANZUS Trauma Grand Round, we run these every 2 months. The first Tuesday of every second month, all of the even months of the year. Mark Sheridan, who is a neurosurgeon from Liverpool, he's chair of the trauma section of the Neurosurgical Society of Australasia. He'll be speaking about managing brain trauma outside the major neurosurgical centres. As many of you may be aware, we previously had a neurosurgical skills course for rural surgeons, which has not been delivered for the better part of 4 or 5 years, but we're looking at delivering that again later in the year. So Mark's going to set the scene with this and just talk about, you know, how to approach these patients when they do need intervention from a surgeon before they can be transferred down to a major neurosurgical centre. Look out for the email or the link on social media, or you'll also be able to get to the link to register via the ANZUS website as well. So I'd like to say thank you very much to you all again, and be safe, and we'll see you all in 2 months' time. Bye.